Welcome to this explainer on cardiac medications. Today, we're taking the really complex world of clinical pharmacology and translating it into clear, actionable knowledge. Our target? The absolute powerhouse class of cholesterol-lowering drugs, HMG-CoA reductase inhibitors. But let's be real, you probably just know them as statins. If you want to understand exactly how these medications work, how to administer them safely, and what hidden dangers you absolutely have to watch out for, you are in the exact right place. Let's jump in.
So here is our roadmap for today. 1. Meet the statins. 2. Mechanism of action. 3. Safe administration rules. 4. Interactions and red flags. 5. Monitoring side effects. And 6. Patient education guidelines.
All right, starting with Section 1, Meet the Statins.
Here is our lineup of common medications on the screen. We've got atorvastatin, fluvastatin, lovastatin, pitavastatin, pravastatin, rosuvastatin, and simvastatin. Notice a pattern here? Yeah, despite varying potencies, they all share that highly recognizable statin suffix. Honestly, in a busy clinical setting, this is your ultimate shortcut. Whenever you see that statin ending, you instantly know you're dealing with a medication designed to lower serum cholesterol.
Moving right along to Section 2, Mechanism of Action. So the technical name is a mouthful. HMG coenzyme A reductase inhibitors. But let's simplify that, shall we? Think of the liver as the body's central cholesterol factory. By acting as a literal roadblock inside that factory, these medications shut down the specific enzyme responsible for producing excess cholesterol. When you block the enzyme, you shut down the whole production line, and systemic lipid levels drop. It's a highly targeted and highly effective process.
Okay, Section 3, Safe Administration Rules.
Now, a really fascinating clinical question comes up all the time with these drugs. Why do we heavily emphasize that statins must be administered in the evening? I mean, why not first thing in the morning with a cup of coffee?
Well, it all comes down to human physiology. Cholesterol synthesis naturally hits its peak while we sleep. The liver's factory is actually working the night shift, so evening dosing is basically a strategic strike. It introduces the roadblock right when the factory is working its absolute hardest. You're aligning peak medication concentration with peak cholesterol production. Makes perfect sense, right?
And this brilliant strategic timing reminds us why we must strictly follow administration rules across the board. It's not just about when, it's also about how much. For example, there are critical dosing restrictions placed on high-dose simvastatin, specifically hitting a limit at the 80 mg level. Pushing dosages too high in certain statins exponentially increases the risk of severe toxicity, and it just doesn't offer enough extra therapeutic benefit to justify that danger.
Which brings us to Section 4, Interactions and Red Flags.
Look, you have to rigorously check for contraindications and severe drug interactions before a statin ever reaches a patient. But you know what the most highly tested and famous red flag is? It's actually a food interaction: grapefruit juice. Grapefruit juice contains compounds that literally inhibit the gut enzymes responsible for breaking down statins. If the drug isn't broken down, it accumulates in the bloodstream. This dangerously alters absorption and can send the patient straight into toxicity. No way around it. They have to skip the grapefruit.
Next up, Section 5, Monitoring Side Effects.
We can't just send a patient home on statins and hope for the best. We have to monitor two absolutely critical lab studies. First, LFTs, or liver function tests. Since the drug is putting a roadblock directly inside the liver factory, we have to ensure the liver itself isn't being damaged in the process. Second, we must monitor CPK, or creatine phosphokinase. Elevated CPK is a primary biological marker for muscle breakdown, which is for sure the most feared complication of statin therapy.
Clinical judgment here is literally everything. You must be able to distinguish between an expected, totally manageable side effect like mild GI upset and a severe adverse reaction. If a patient reports severe, unexplained muscle pain and their labs show massive CPK spikes, that is a blaring siren for rhabdomyolysis. That's a rapid, dangerous breakdown of skeletal muscle that can actually lead to kidney failure. Knowing the difference between a simple tummy ache and massive muscle toxicity saves lives.
Finally, we've reached Section 6, Patient Education Guidelines.
Before discharge, you are bringing the client in as a partner in their own care through 3 sequential steps. Step 1, discuss dietary modifications. Statins are incredibly powerful, but they don't replace a heart-healthy diet. Step 2, explicitly instruct them to report any unusual muscle pain or weakness immediately.
That connects right back to our CPK watch. And step 3, ensure they actually have those mandatory follow-up LFT labs scheduled, so their liver function is securely tracked over time.
So I'll leave you with this final thought. We've seen how statins strategically hijack the liver's night shift, why a simple glass of grapefruit juice is suddenly a dangerous enemy, and how a random muscle ache can actually signal a life-threatening complication. These aren't just everyday pills. They are profound biochemical tools. Are you and your patients truly equipped to respect and manage that kind of power safely? Thank you for joining me for this explainer on statins. Keep questioning and keep learning.